Hi, I am Dr. Sridhar Kalyanasundaram. I'm a consultant neonatologist. Welcome to my channel and thank you for your positive feedback and for subscribing and sharing the information. So this is the second video on oxygenation, and I hope you watched the earlier one, which gives us an overview of the importance of getting adequate oxygen to the tissues and how the various deficiencies of oxygen and things impact the body. So in this video, we are going to focus on what tools we have to measure oxygenation, and in the following video, I'll be discussing on target oxygen saturation that we will use. So this will be a PowerPoint presentation and we will go through. What are the clinical tools to measure oxygenation? So we can have the partial pressure of oxygen. This measures the oxygen dissolved in the plasma, and as we discussed in the previous video, this is a very small proportion. And arterial blood gas sample is usually used to measure this PaO2. And we can do the arterial measurement either from the umbilical or radial posterior tibial cannula. The most accurate measurement of oxygenation is the PaO2, and it's a little difficult technically as it is needing an invasive measure. Not all babies have an arterial line, and we try to minimize interventions. We try to reduce the number of days baby has an arterial line. So even if they have it initially for blood pressure monitoring mainly, very rare that we insert an arterial line just to monitor the PaO2. We would be monitoring the blood pressure as well through that, and obviously in the very tiny babies it reduces the need for pricking the baby frequently in the acute stages when they are very fragile. So it is invasive and it's also more expensive. Continuous monitoring is not routinely available, and intermittent measurements are used. So even though there is an option to connect your UAC or other arterial lines to a continuous transducer, most of us use intermittent blood gas measurements through the samples taken. For those of you who are wondering why the umbilical artery, the line curves down and then comes up, this is an anatomic representation. So this is the start of the umbilical cord, and these two are the umbilical arteries. So this is the catheter which is going in through one of the umbilical arteries. So you can see that the umbilical artery actually joins this gluteal artery, one of the branches of the internal iliac, and then it goes through the aorta through the internal iliac. So the looping down is because of this, that it doesn't go to the aorta directly. It goes through a branch of the internal iliac, enters the internal iliac, and then curves up into the aorta. So it's very important that we use this as a confirmation of whether it is in the umbilical artery or not. This also illustrates the different positions where an umbilical arterial line may be located. So we have the celiac trunk, we have the renal artery, we have the superior mesenteric and the inferior mesenteric vessel. So you have to keep it away from the origins of these vessels, and a high position you can go up to T4, T5 even before the internal mammary branches start, and then you have to keep it in a low position below these vessels. So either you target this area or you target this area, and it's very important to avoid the origin of the renal vessels, as you may have a clot originating in the tip which extends and causes problems. So that is about partial pressure of oxygen, and it's mostly used in the first 2-3 days, and when we remove the umbilical arterial line, you will not usually have the PaO2. In transcutaneous oxygen, TCPO2 measures continuously via the transcutaneous sensor. The sensor needs to be heated to allow the measurement. It acts by diffusion at the skin level, and because it's heated, it needs to be resighted regularly to avoid burn. So every 4 hours or so, you need to resight it. It's cumbersome to use, and most units do not use this anymore as saturation is adequate in most situations. We do have it in our unit, and we specifically use it for situations where we don't have an arterial line and we need PaO2 measurements. So it does help you to titrate without doing enough more blood gases. And when we don't have an arterial line, the venous or a capillary blood gas samples do not give you an adequate representation of the PaO2. So you use it as a guide for the pH and the carbon dioxide, but you don't use the PaO2 anymore on those samples. So if you talk of a blood gas and PaO2, it has to be an arterial sample. capillary or a venous sample, it's very difficult to deduce because the tissue uptake of oxygen, as we discussed in the previous video, varies a lot. So this is an image of a baby having transcutaneous oxygen and PCO2 measurements. So you can see the oxygen below and the PCO2 is above, and it gets a good reflection of the trend. So it's theoretically a good tool, but in practice, because of the problems and the burns can be cumbersome, we don't use it that frequently. But it's a useful tool in some situations if you have it. Most important monitoring tool we use for oxygen is the oxygen saturation, and as we discussed in the previous video, it is a reflection of how much of the hemoglobin that is available is saturated with oxygen. So the oxygen content also depends on the content of hemoglobin, not just on the saturation of hemoglobin, and both are important components. So the saturation can be measured peripherally as we use on a saturation monitor when we call it as PO2, or it can be measured on the blood gas where it is a measured sample SaO2. It measures the proportion of RBC where hemoglobin is saturated with oxygen. Because it depends on pulsatile flow, any situation which affects tissue perfusion like shock and movement artifacts, hypothermia, and because of the light being involved, light exposure may also affect reliability. There are recent advances like we have in the Massimo monitor signal extraction technology, and this helps to overcome some of this quicker averaging time without affecting accuracy, and movement artifacts are reduced as well. So this is a reflection of the monitor. The probe is placed on the foot of the baby or on the hands of the baby, usually sometimes on the earlobe if the baby is big enough. Different sizes of the probes are available, and basically the pulse oximeter works by having a red and infrared light emitted from a light emitter on one side and the detector is on the other side. So they have to be opposing each other, and there shouldn't be anything interfering with the measurement. Movement artifacts can affect, and if there is external light, it may affect, so you may cover it up with something opaque. You need pulsatile flow, so the tips of the fingers are usually vascular unless you are hypotensive or cold. So the pulsatile flow is taken because the capillaries and veins also have hemoglobin in them, so it only takes up the extracts the pulsatile flow. The sensors detect how much oxygen is in your blood by comparing how much red light and infrared light is absorbed by the blood. Depending on the amounts of oxygenated and deoxygenated hemoglobin, the ratio is compared to the amount of red and infrared absorbed. So it changes depending on the algorithm. So this is the algorithm that is used by the microprocessor. For the same reason, different companies have slightly variable measurements for the same reading because their algorithms are slightly different. And it tells you oxygenated hemoglobin, deoxygenated hemoglobin, how much of the red and infrared is coming back. So again, a reflection of the same. So the factors we should consider is the fidelity of the monitor and the improvements that we have like the SET technology. Pulse averaging time is, as I said, it picks up on the pulsatile flow. It doesn't read for every pulse beat. However, if there is a faster averaging time, the changes are more accurately reflected. The labor room, you may use a faster averaging time, so it picks up faster, and it can be slower in other areas. So movement artifacts are reduced. The quick fluctuations that happen may reduce if you have a faster, slower averaging time. Limb movement artifacts and temperature and peripheral perfusion are also important issues to consider. When we talk of newborns, we also have to consider the pre and post-depthal saturation, and obviously all of you are familiar with the critical congenital heart disease screening, where we use a pre-ductal measurement and a post-ductal measurement, usually in the right upper limb for the pre-ductal and one of the lower limbs for the post-ductal. And this is just to make sure that we are not missing differences there. The ductus arteriosus is basically connecting the descending aorta with the left pulmonary artery, and this blue vessel is the ductus arteriosus, and this is joining obviously after the left subclavian originates, but sometimes it's almost at the same level. So the left side left upper limb may or may not be preductal or postductal. It's difficult to predict. So we use the right upper limb as the preductal and the lower limbs as the postductal. And when there is physiologic pulmonary hypertension, the resistance to the blood flow in the lungs is high, and so the shunt through the patent ductus arteriosus may be fluctuating from right to left for a period of time when the lung pressure is high, like when the baby is crying or when there is a little hypoxia, when the lung vessels may constrict, or it may fluctuate to a more open pulmonary circulation and it becomes a left to right shunt, in which case we won't have a pre and post ductal difference. So the PDA closes over the first 2 to 3 days, and after this the pre-post ductal saturation should not be different. So we are specifically talking of oxygenation to the brain, which is from the pre-ductal, and so we prefer to titrate your oxygen depending on the pre-ductal measurements rather than post-ductal. So you may end up giving more oxygen unnecessarily to the baby if you have post-ductal saturation recording. So keep an eye on that. If you need to keep increasing the FiO2, double check that there is no pulmonary hypertension. And if there is pulmonary hypertension, obviously you need to do an echo and make sure that baby doesn't need anything more to help. So we do have alarm settings on the pulse oximeter, and we should be careful about how we set the alarms, and we should decide a target range to maintain. It should not be too high to avoid hyperoxia. It should not be too low to avoid hypoxia. So your alarm settings are going to be a different range from your target saturation. Usually the lower limit is 3 to 4 lower than your set target range, and the upper limit will be 1 or 2 higher than the set target range. It should not be too narrow as well. We don't want to keep our target range as alarm limits, because then you may have repeated alarms and it might cause alarm fatigue. It also causes unnecessary changes. Sometimes you may increase FiO2 for something which is very transient and which would come up anyway. A clear response plan should be communicated to avoid excessive action. So we can say that if the saturation drops below your alarm limit and stays that way for more than 1 to 2 minutes, you may change. Unless it needs more urgent intervention, you will obviously be looking at the baby as well. So for example, we aim to keep 90 to 95% as a target range. We will be discussing this in more detail in the next video as well. The alarm limits can be set at 87 for the lower limit and 96 for the upper limit, as we use in my unit. And this is, as we discussed, you don't want it too close to the target range. You don't want it too narrow as well. But at the same time, the upper limit should be always set for any baby needing oxygen. So if your baby is having even a low level of oxygen, you need to keep the upper limit on, because you don't want hyperoxia. However, the level to which hyperoxia will happen depends on how much oxygen you are giving. So if you have 0.25 oxygen, you're less likely to cause very high level of PaO2 compared to when you have 0.3 or 0.4. In these cases, it would be criminal not to have your upper limit set, and you need to titrate it down the moment it is more than 96. Repeated education sessions and monitoring for nursing and physician teams is important for the same reason. So we should be well aware, we should keep discussing. Any colleagues notice that the saturation is more than 96 and someone is not acting when their FiO2 is higher, you do feedback to them, do educate them. We will be discussing in the next video about how oxygen can be harmful to the baby, and so that is important that we look at aspects to avoid oxygen toxicity as well. So mainly reducing the risk of ROP, reducing the risk of chronic lung disease progressing, and obviously hypoxia is also not good for the baby, as repeated hypoxic episodes may affect your neurodevelopment. So how does the saturation correlate with the partial pressure of oxygen? So we have many studies which have looked at this. In a study of 98 consecutive infants born at less than 29 weeks that compared the paired saturation and PaO2, the mean partial pressure of oxygen at 85% saturation was 40 with a range of 29 to 51. And at 95% saturation, the mean PaO2 was 54 with a range from 41 to 67. So the alarm settings, as we discussed, will be around this range, so we are fairly safe in most situations. And as I said earlier, the amount of fetal hemoglobin and adult hemoglobin will affect the saturation reading you get as well. In another prospective multicenter study of 122 neonates that compared 976 paired saturation and PaO2 measurements, the saturation values between 85 and 93% The mean PaO2 was 56 millimeter mercury, and approximately 87% of the PaO2 was between 40 and 80 millimeter mercury. So even with 93 saturation, a good number goes up to 80 millimeter, and 9% were below 40 and 5% were greater than 80, even at 93%. When saturation was greater than 93%, the mean PaO2 goes to 100 plus, which you don't want. And approximately 60% of the PaO2 values were greater than 80 in these situations. So it's very important that we monitor and titrate according to the needs. And when you say a target range of 90 to 95, you will have briefly hitting 95, but as long as it's in that range, it should be reasonably okay. And as I said earlier, the PaO2 will not go excessively high if FiO2 is not too high. And we discussed this earlier, the transfusions can affect this by changing the proportion of fetal hemoglobin, where the shift to left happens, and adult hemoglobin increases, there is a shift to right. So at a relatively same PaO2 level, the saturation is higher if you have more fetal hemoglobin, and in the same baby, after a couple of transfusions, the saturation at a given PaO2 will be lower. So you have to account for that when you adjust your target range. However, if you use a range which is reasonable, if it comes to the lower edge of the range after transfusions, you accept that. There is a higher risk of retinopathy of prematurity with multiple transfusions, and this is related to this hemoglobin binding factor, how easily it's released to the tissue. So the fluctuations that happen leads to fluctuations in the vascular endothelial growth factor levels, and that leads to a higher risk of ROP. Lastly, we will have a quick look at near-infrared spectroscopy and how it works. So we discussed oxygen consumption in the tissue. So we have the oxygen in the arterial system, and then the oxygen extracted in the capillary level, then the returning blood has lower level of oxygen. So oxygen consumption can be calculated as a function of the cardiac output and the arteriovenous difference, and the resting VO2 is approximately 4.5 to 7 ml per kilo per minute during the first month after birth. The near-infrared spectroscopy tries to measure this, and you may have probes at different levels to see the differential consumption. You may have it at the limb level, you may have it in the abdomen to measure renal perfusion, and you may use it over the brain. So the oxygen extraction can be used as a sign. If there is sepsis, for example, there will be excessive tissue consumption, and hypotension doesn't allow adequate extraction. So if there is septic shock, for example, the blood goes through fast, it's a dilated system, so the extraction will be lower. And if it is a stagnating system where the enough blood flow is not happening, or there is more time that it stays in the tissue, then you have more extraction. So you can use these as a guide to help you with hypotension management as an algorithm as well. So you use echocardiography as a guide, you can use near-infrared spectroscopy as a guide as well to know how much brain perfusion is there. It's still not well established in clinical practice, and not many units have near-infrared available to them. And it's a useful tool to monitor treatment asphyxia and also to titrate your response to shock and hypotension. However, we still need to await some more information, more training before we can apply it in clinical practice. So to summarize, pulse oximetry is the most important clinical tool to monitor oxygenation. So we should be well aware of the pros and cons, the tips to use it appropriately. For example, if you're going to the labor room, it has been well established that if you connect the probe first to the limb, you switch on the monitor, and then you connect the interface between them. So the probe and the monitor are connected after you have done both stages. It picks up quicker. And using some monitor with signal extraction technology, for example, may be able to give you readings faster. We should use a saturation as a guide, and in most instances you don't need the arterial samples, because nowadays we don't ventilate long term. We try to extubate at the earliest, and as long as you understand that you are within a range, you understand what you're doing, you accept a little bit of physiologic hypertension, pulmonary hypertension, you titrate through that phase. You don't overdo your ventilation. So over-ventilating also is harmful. It affects the oxygenation in the lungs as well. And other tools like transcutaneous and NIRS are not routinely used, and obviously you have selective situations where it may help you. So as I said, I'll be making the next video on oxygen toxicity and oxygen saturation targets. So do subscribe, do share with your colleagues, and if you are seeing this post on a Facebook group where there is no sharing option because it's a private group, you can always copy the link from YouTube and share it on your WhatsApp groups or other social groups that you have to colleagues who might benefit. And do turn on notifications so you get informed when the next video is coming out. I hope this is helpful, and thank you for watching, and look forward to interacting more. Bye.